look at basics in spinal anatomy, and then look at few ways to classify the spinal cord vascular shunts, and we will look at example of each, how it is presenting, and then we will discuss two common ones, which are spinal cord AVM and spinal dural fistulas. And I will show two metameric AVMs and how we deal with it, because sometimes we get the whole package. So that's what we're going to do. So going back to the basics, I like to show this one. So this is the best picture of segmental anatomy. The picture on the left is the vascular system of the earthworm, and the picture on the right lower down is the nervous system of the earthworm. So earthworm is segmental, so it has got each segment.
Hi, Sid. Sorry, I can't see the slides. I don't know if that's the same for everybody else.
Oh, you can't see the slides?
Oh, they've come through now.
Am I not sharing it?
No, you are. You are. It's just
it
was just lagging a bit. Sorry.
Right. So for some reason, so the Wi-Fi should be good. I'm at home.
Yeah, no, I can see the earthworm now. Sorry for interrupting.
Yeah, no problem. So this is the earthworm. So the picture on the left is the vascular system, and the picture on the right is the nervous system. So it shows you each and every segment. It shows you the central nervous system part and the peripheral nervous system part on it. And then the vascular system shows you the chambers of the heart and how each segment has got its own circulation on that, and how the aorta runs throughout the length of it. So this is the microscope image of an embryonic zebra fish, which is favorite fish of Pierre Lajunius, and he used to always show this picture, and he used to show that how the segmental system is arranged in the spinal cord as well, and the branchial arches, how it develops. So the second picture, which is on the right lower portion, is just the evolution to show that this is how we have evolved, and how man has evolved from primates to human walking around. So that's how it is. And when we look at it, even our body is segmental. When you look in this picture, you realize that the thorax is segmented, but you try to get confused when you look at the limbs. But then if you put this in this perspective, you quickly realize that, yes, the whole of the body is also segmental. So that's what we need to look at. We were four-legged animal before, and then we have stood up, and that's why the segmental system looks different. So this is the embryogenesis. So where we can see in the stage 6, we get the gastrulation, and then as the embryo starts developing, you develop the somites. And the French word for the somites is a metamere. The somites are there, and by the time we go to stage 13, you have a well-formed baby, and the neural system starts developing at that point. So here is the picture from surgical neuroangiography. So I'd like to refer mostly to surgical neuroangiography as the basic book for any INR trainee to refer to, because they have described it very well, and even the presentation is good. The first chapters are basically concentrating on spinal anatomy. And once you understand the spinal anatomy, it's easier to extrapolate whatever you learn in the spinal anatomy into the cranial anatomy. So here you have on the image on the top, where you can see that that's the aorta, and then that's the central nervous system and the peripheral nervous system and the neural crest cells. So you have the dorsal ramus, which supply those two, and the ventral ramus, which goes towards the alimentary tract. This is the same pattern which appears in the intercostal and lumbar region, where you have the dorsal trunk, which supplies the central nervous system, peripheral nervous system, and the musculoskeletal system around that. And the ventral arteries supply the GI tract. But when we come towards the brain and to a head and neck, there is a shift. So you have the transfer of the peripheral nervous system blood supply to the visceral system, and the arteries which go towards the central nervous system remain as they are. So these are the cerebral arteries and the ventral ophthalmic arteries, while all the other arteries which were previously supplying the peripheral nerves, they get transferred to the alimentary tract supply, which is the external carotid artery branches. So that's what happens. So Going to the next, this is how the images, this is again from surgical neuroangiography. So this is how it shows the central nervous system, where spinal cord, brain stem, brain, optic nerve, and olfactory nerve, while the peripheral nerves are the cranial nerves and the branchial arches and the digestive system. So that's how it shows, and the blood supply going towards the heart. So to start off the introduction, the spinal vessels, they form a grid from embryonic segments of metameric vessels along the length of the neural axis. And then you have the segmental cord supply in the cervical portion. So is the thyrocervical trunk, which gives the lower part of the supply to the spinal cord. And the costocervical and the deep cervical, which is at the back, that gives you the further up. And then the vertebral artery at the level of C1. And then the pica, ECA branches, occipital, they go to the neuromeningeal trunk and supply the lower cranial nerves. So that's how it happens. And in the thoracic portion, you have the segmental arteries, which are the supreme intercostal, which are intersection of 3 or 4 intercostal arteries. And then you have from T5 to T12, each will have their own individual artery on the right and left. And they may contribute towards the spinal arteries, that is the anterior spinal axis, as well as the posterior spinal axis. Then you have similarly the lumbar area, where you got the lumbar, median sacral, iliolumbar, and lateral sacral. These are the ones which are segmental arteries for the lumbar region. So to understand that, we say that from the aorta, you get the dorsal branch, which goes towards the back, and then it divides into different branches. The dorsal trunk, which goes into the spinal canal, and then you have the ventral trunks, which are going along the musculoskeletal area. So here you have the image where you can see the branches which are going posteriorly, the anastomose across the midline. So that's where the anastomosis is, across the midline. And can you see the marker coming up? For some reason, my pencil seems to.
No, we can't see the marker, Sid.
Yeah, so I'm trying to see if my pencil works. My pencil has stopped working anyway. So the whole point of having iPad was to be able to use the pencil. Okay, so it's saying, yeah, that's fine. So let's see if now it's connected. Yeah, there. So this is the part where it anastomosis all around the spinal canal. And then you have the paravertebral anastomosis, which is just in front of the transverse process. And then you have further on here and at the back here. So the one which is at the paravertebral across the transverse process, this is the one which defines the vertebral artery in humans. So it's the anastomosis. So here you can see this is the segmental arteries which come out, and this is the vertebral artery, which is just the anastomosis. And at the C1 it enters. So this is the embryonic segment, while this is all the anastomosis between the segments. Then you have the thyrocervical artery, which gives the lower portion, and then you have the deep cervical artery here. So you have the proatlantal artery and the hypoglossal artery. So these are all the peripheral nerve supplies, and they contribute to the anterior spinal axis also if it enters into the canal. So this is a basic diagram which I like to refer, and this gives you everything about how the spinal anatomy is, the vascular anatomy, and it is like peeling layer by layer. So I will go, when we go across, I will keep explaining. So this is now focusing only on the musculoskeletal part of the blood supply. So the dorsal spinal branch supplies the posterior elements of the vertebral body. So this is where it goes, posterior elements of the vertebral body here across. And also it goes posteriorly to the arch as well. So down there at the back also. So it goes behind the thecal sac and supplies the posterior spinous process as well. So the epidural branch are the ones which form the network. They form this rhomboid portion around. So this is where it is the anastomose with the layer, the segmental artery above. So this keeps on forming a rhomboid around like that. So at every level, you will have the same rhomboid structure coming up like that. So it keeps building like a brick layer there. So this is what we are seeing. And then you have the dural branches. So these are the dural branches. These are the branches which they form horizontal. They go across horizontal and they anastomose across the midline like that. And then you have another one coming from like that. So when we look at the dural avium, these are the branches which supply the dural avium. So I'll explain to you when we come to that. So The dorsal spinal also gives rise to radicular artery, which tracks along the nerve root. So they track along the nerve root and ascend. So this is the artery which tracks along the nerve root and joins the spinal cord. So when it joins on the anterior surface, it forms the anterior spinal axis, while when it joins laterally onto the part outside, so that forms the lateral spinal artery. So that's called as a radicular artery, while the one which joins the axis, it's called the radicular medullary artery. Okay, so we need to understand more about this. So let's look at the diagram. So we know that the segments are somites or metameres, as we call them. Each one will have their own supply, which comes from each side. So this is the early part of the embryogenesis. You have each branch coming from each side, and then they start fusing. So they start forming the fusion all along the length. So each side on its side will fuse and form that. And when the next step arises, so they start showing redundancies, and then these are the radicular arteries which will stop here, supply only the nerve root, while there will be some dominant ones which will go and join the anterior spinal axis, and these are the radicular medullary arteries. So this is a radicular artery, and this is a radicular medullary artery. This is the nomenclature we use to describe the arteries when we do the angiogram. And as we know that the spinal cord doesn't lengthen, and because there is a apparent lengthening of the vertebral column, so the nerves are stretched. Similarly, the arteries are traveling along the nerve root, so that's why you have all the arteries going up, joining the cord, and coming down, forming the hairpin bend. So this is a diagram just explaining that. So like I said, the brain is extension of the spinal cord. So this is the radicular medullary artery. This is the vertebral artery. And then when you come to the craniovertebral junction, it's as if since we started becoming erect, we are looking forward now. So our head has turned 90 degrees because we have stood erect. So what that has done is, so the ICA is the radicular medullary artery. That's the posterior division, that's the anterior division, and that's the parietal artery, anterior cerebral artery, which forms the limbic system. So that's what it does. So I'm not going to go into all that, but we need to understand basic that if we understand the spinal anatomy and the spinal blood supply, we can extrapolate that to the brain as well. Now, there will be a question which one of my medical students asks, how does that work? Because the spinal cord, the gray matter is on the inside and the white matter is on outside, while in the brain, the gray matter is on the outside and the white matter is on the inside. So how do you say it's an extension? So the answer to that, which I was explained, is because during the development of the brain, is the gray matter which migrates from the ventricular surface towards the cortex. So they migrate in 6 layers. So that's why it is the spinal cord, but because they have to accommodate more surface area, the gray matter have migrated in layers to the surface. That's what's happened. So we come back to the radicular medullary artery and the radicular PL artery. So you have, which is a branch of radicular artery which joins the anterior spinal artery, and there are 6 to 10 in numbers, and they can be identified on angiogram. They are midline in location and have a sharp hairpin bend, while the radicular PL arteries are seen more common, and they are around 20 to 30 of them, and they have much more sharper curve, and they don't come to the midline. They're just slightly off midline. So anterior spinal artery, along with its accompanying vein, travels in the subpial space. So this is important to know because if we have cord signal change and if there is congestion, you may not see the veins in the subarachnoid space because the anterospinal vein is subpial, while the posterior spinal veins are in subarachnoid space, which you can see. Now, going back to the previous image where I showed there was a fusion. So the anterior spinal artery, each branch of the anterior spinal artery which digs into the spinal cord will supply only 1/2 of the cord. So this is the picture which shows you the anterior spinal axis, and this is the picture which shows the 2 posterior spinal arteries. And this is the image which shows you the posterior spinal arteries, which is slightly off midline, and it is more sharper in curve, and that's the picture of the vertebral column where it shows the spinal artery is on the side here, and this is a subtracted view of the same. So this is what I was referring to. So the anti-spinal artery gives rise to each branch. So each branch will just supply only one half of the cord, and it will anastomose with the lower branches of the same side. So the important thing to remember is when we are dealing with embolization in the anti-spinal artery, we have to make sure that we go into a branch selectively and off midline. So what happens is these are all perforators which come up. So this is the anti-spinal artery coming up. And then when you go into this branch, so when you start embolizing from here, you will have only that half of the spinal cord at risk. But if you stay in the anterospinal artery, you would have the whole of the spinal cord at risk, and which puts you having complete paraplegia. While if you are in a branch, you will have only one half of the body affected. That means only one lower limb will be affected. So that's the important bit we have to remember. And if you are further in, even if you block that branch, there is anastomosis within the system, so you can still have the normal brain functioning, normal cord functioning. So that's what happens. So that's the same image explaining to you only one half of the cord is involved, and it shows you the supply to the gray matter. So this is how the images are. So that's showing the fenestration. That's the anterospinal artery from each vertebral artery, and that's the fenestration which happens at the vertebral junction. That's because of two equal competing blood supplies coming through the spinal cord. So that's the image which shows you the distribution of the cord. So most of it is supplied by the anterospinal artery, and the posterior part of the cord is supplied by the two posterior spinal arteries. Important, another point to remember is the basket. So this was the images which we got from surgical neuroangiography. I think I also have got some images which I'll show you later on in the presentation. So here, when we inject on this artery, so it goes down from the basket and then comes back up to supply the AVM. So when we do the injection in the anterospinal artery, you do see something. Sometimes the posterior spinal artery is filling. So the posterior spinal arteries and the anterospinal artery, they form a basket at the conus. The spinal cord venous drainage. So just like in the brain, the spinal cord has got transparent camel embryonic veins, and it has got venous drainage, which consists of intrinsic venous system, extrinsic, and you have radicular veins, and these radicular veins open up into the paravertebral plexus. So the intrinsic venous system is made predominantly with axillary veins. So this is an image from Lajunia's book, and it shows you that extensive anastomosis which happens inside the spinal cord. The extrinsic venous system is made of pal network, which is similar to that of veins which are in the subarachnoid space. There is one longitudinal collector vein which is in the ventral surface, while there will be probably one or more at the posterior surface, which is in the subarachnoid space. So this is the patient who was being investigated for the cord signal change, and this is the angiogram we performed. We couldn't find any spinal AVM. So what you do in this is, if there is a strong suspicion, what you have to do is you have to inject into the anterior spinal artery, and you have to wait towards the final pictures where you see the spinal veins. And this is the injection in the early arterial phase. That's the capillary phase. That's a C, and that's a A. And this is the venous phase where you can see the emergence of the radicular veins. So, sorry. So that's how it happens. So you can see, so the venous system is normal. So there is no evidence of any venous hypertension. So the longitudinal collector veins subsequently drain into the adjacent radicular veins following the ventral and dorsal nerve roots. But it is not necessary that the veins will open along the nerve roots. They can open out into the paravertebral plexus in between the nerve roots as well. So that can also happen. So you could have dural fistulas which are arising without having ascending through the nerve root system. the venous system. The venous system of the cord is devoid of valves, allowing for retrograde venous flow and subsequent venous congestion in the conditions associated with increased pressure within the paravertebral venous plexus. So suppose you have a paravertebral AVM, or if you have an epidural AVM, you could see them refluxing into the spinal veins. So this is the picture of the venous congestion, and you can see that this is the early phase where the vein joins the anterior spinal axis, goes down, and then once it reaches the basket, it comes back up and then starts congesting the whole thing here. So you can see that. So this is the one in the, sorry, I said it wrong. So this is in the posterior portion, while this is in the anterior portion, which is the subpial portion. So that was basics regarding the anatomy of arteries and the veins. So I will just spend some time on how I do and how I was taught to perform a spinal angiogram. So what I do is things to get before starting the procedure, and we do the consent to do the procedure under general anesthetic. And sometimes we need to give apnea if we are concerned that we are not seeing the spinal arteries or the spinal arteries are very small. And we use 4F catheters. So my go-to catheter is Termo Glide Cath, Cobra, or a Sim1. So this is my go-to catheter. So if you are dealing with cervical shunts, then you can use anything else like a vertebral catheter. Most of them vertebral arteries are quite stable, large, so you don't have an issue at all. So you can take 6-foot system as well in that. So then we do the chart of the documentation. So this is how we have a chart of spinal angiogram. We put it at right and left, and then we put all the anatomy, and then we label all the levels. And then when we acquire the sequence, then we write down which sequence has what. And then we mention that on the T11. So here we have got on the T9, which is a sequence number 8, we got something the anterospinal artery. So this is how we document it. So it becomes easier when you start labeling them. So intercostal artery and rhomboidal arteries are very tiny. The capacity of the artery is around 1 ml only. So you cannot inject more. If you inject more, it all reflexes back into the aorta, and then it just causes confusion. You see many other levels coming. So we have to inject very slow. We inject maximum 3 ml and over 3 seconds. So none of my spinal injections take more than 3 ml in that injection, even if I think there is something. So I go very slow and very steady, and I inject that. And the images which I acquire are 22 mag. So we use a Philips biplanar system, and so I never take laterals for spine because it just doesn't make sense. It's too much radiation dose. So most of my spinal work I do only in a single plane in AP. Sometimes if it's near the cervical portion, so then I can do a 3D or something, or if it's very complicated, only then we do 3Ds. Otherwise, if you know your anatomy well, you just don't need to do a lateral at all. So you can just make decisions on the AP projections itself. Because the radiation is high, you don't need a high frame rate, and the flow through the spinal arteries are quite slow. So you can do with 2 frames per second for 3 seconds, and then 1 frame per second for the rest of it. So the initial arterial phase is what you want to get most of the time. And then the venous congestion, you don't need to have that high frame rate. So you can go with a half a frame per second as well, or 1 frame in 2 seconds. So that should also be okay. To demonstrate the venous anatomy, so I inject 10 cc over 12 to 5 seconds. What it does is, if I have not found a shunt and I'm doing a spinal angiogram, and there's a strong suspicion, and I now need to demonstrate that the veins are normal. So then what I do is I inject 10 ml, and I inject this extremely slowly, around 12 to 15 seconds. So what it does is it floods the anterior spinal axis completely for 12 seconds, and then that is a frame rate of 1 frame per second for 10 seconds, and then 1 frame per second for 2 seconds, 1 frame per 2 seconds. So till the whole venous anatomy is seen, we just keep going at that speed. So this lowers the radiation, and then once you demonstrate the normal veins, then it's fine. So that's the technique how I use in our department. And we go down to now spinal vascular shunts. So they contribute approximately 2 to 4% of the total space occupying lesion. And the incidence of spinal vascular malformation to the brain vascular malformation is reported 1 to 4 or 1 to 8 by different studies. So there are lots of studies out there. So Pierre Lajunius used to classify them in this manner. So he used to say that we can look at it as a genetic hereditary, where it common presentation in pediatric age group. Then you can also say whether it is syndromic or whether it is metameric. So that's what he does, and he calls them SAMS, spinal arteriovenous metameric syndrome, and he names them 1 to 31 as well. So each segment is named. Or then he puts it as a focal, which means you have a single component of the metamere involved. So in the intradural part, it can exist either right from the phylum terminale, which is the lowermost part, or it starts at the root, which is the spinal artery supplying the root itself, or on the cord, which could be either supplied from anterior spinal artery or the posterior spinal artery. Now, the extradural components can be either dural avium, epidural avium, or paraspinal avium. So usually I struggle to differentiate between epidural and dural. I can easily identify what's a paraspinal. So I would consider epidural as dural avium itself. So that's what I would put it as. So this was the other classification which predates, and this is what commonly the neurosurgeons like to refer, type 1 fistula. What they mean is a spinal dural AV fistula. And then when they say type 2 means intramedullary, means a proper normal spinal cord avium. So I have yet to understand what type 3 juvenile avium, intra-extramedullary, I couldn't get my head around that. And then type 4 perimedullary, it will still be classified as a spinal cord avium itself. So basically what we're dealing with in neurosurgical terms is spinal dural avium or spinal cord avium. Now, this is a paraspinal avium where you can see both the vertebral arteries have been injected, and it shows a right-sided paravertebral avium. So, and then that venous drainage is congesting the spinal cord veins, and you can see the midline spinal cord vein going up. So that's what it is. So this is a left vertebral injection, and that's a right vertebral injection, and the avium is located in this location here. So this is a radical avium. So this is a picture from Lajunias. He had given me this picture. So this is the supply on the nerve root itself here, and then it drains into the anterior spinal vein going up. So that's the anterior spinal artery coming down. And here you have the MR scan, which shows you the avium on the nerve root. And this is the another injected specimen, which shows that appearance. So I can't figure out what that exactly is. But he had said to me that this all leash along the nerve root was abnormal, and this was probably what was the vascular malformation. I would have thought that this is what it would be mentioning. So this is another one here. So we can see on this, there is a significant cord congestion. So you can see lots of subarachnoid veins, and can't figure out what this one was. This is the anterior spinal artery coming in there and going down, but we couldn't identify anything out there. So then we have this appearance of the T11 intercostal artery, where we could see a leash of vessels. So you can see this. This is probably on the nerve root sheath, and then you have the spinal vein coming in, going towards the midline, joins the cord, and then goes down. And it goes all the way down. And this is the portion I was saying. This is going along the anterior spinal axis, comes down, and this is at the basket where it divides and starts going into the posterior spinal veins. So this is how it does. So this is a radical avium. So how do we treat this? So we go super selective. And before we go there, we have to identify the anterior spinal axis and make sure that there is no hidden anterior spinal axis coming from the same level. So we injected the level below this is left T11. So we saw this artery, which is coming down, and then we saw the opposite faint artery. So this is filling from the opposite side. So we need to make sure which one is that. So we injected that again. So we injected the right one now. So the right one, when we injected, we have filled that bit and faintly opacified the other one here. But if you see carefully, so you can see that when we injected on the right, we can see one artery here, and then there is another artery at the back here as well. So there is a second artery here. So these two arteries cannot be both anterospinal arteries. So this is the anterospinal artery and this is the posterior spinal artery. And that in turn tells you that this is the posterior spinal artery. So what do we do? So we have to treat this, but this is on the left side. Left side is technically challenging. So the Cobra catheter hooks onto the origin here, but it is very unstable. So with that position of the catheter, you cannot navigate all the way in. So you have to get your catheter stable and then start. So what I had to do was I had to put a microcatheter all the way up to here. So this was the Traxxas, it was headway 17 with a Traxxas wire all the way up to here. And I changed the Traxxas wire to a stiff coronary wire. So once the stiff coronary wire goes in, and then you can track the glide cut up to here. Once you have the glide cut up to here, you can start putting the magic or the sonic catheter, whichever you want to use. So with that catheter once in position, so I have put the detachable tip catheter up to here. So that's the distal tip of the detachable catheter. That's the detachment marker. And once you're done that, you're gone into that, so you can slowly ease your guiding catheter back. And following that, we navigate all the way right up to the origin of the artery supplying the vein. So this is what we needed to do. So we have reached super selectively all the way to this point, up to here. And then you have this leash of vessels on the nerve root and then that coming off. So that's the glue injection from there. And we have injected the whole thing here. And that's the post-injection. Then we come to the next one, which is a spinal dural AV fistula. This is the most common spinal vascular malformation in adults presenting on the 4th or the 5th decade with male dominance. So this is mostly either due to venous thrombosis, post-surgical or post-traumatic. It is slowly progressive over a few years with motor and sensory symptoms. So when the story comes that they have been slowly, progressively getting worse, initially started with weakness in the legs, then it progresses into a bladder bowel involvement. And previously, before we understood this condition, there was a condition called as melting cord syndrome, which means that at that point, they could not pick up the spinal dural avium, and the cord used to be absolutely atrophied, and because of the venous congestion, it would go into gliotic changes. So that was melting cord syndrome. So spinal dural AV fistula anatomy and physiology, pathology. The shunt is usually a single fistulous communication between radicular artery and an accompanying vein. It is on the inner surface of the dura at the level of foramen between the pedicle, and it could be medial to it. So commonly located in thoracolumbar region D5 to L3. 10% of cases are radiculomedullary artery or radiculopyre artery will also arise in the same. So that's the normal statistics with any dural branch and radicular artery. The draining radicular vein pierces the dura some distance away from the accompanying nerve root to drain into the perimedullary venous plexus. So that's the standard thing. So there is no role for CT myelography on diagnosis of this. So MR will show you lots of abnormal flow voids, which are seen on the dorsal aspect, which is in the subarachnoid space. You will see the cord signal abnormality. MR angiograms, echo sequence is what they used to say, and they used to say that that can identify the site of a fistula. Somehow I have struggled to get that, and we rely more on angiogram. Sometimes it does give you an odd indication that this could be at that certain level. So we start investigating from that level and then move forward. So the best option for this is to disconnect the vein, and it's easily done surgically. So what they do is they cut open the dura, they go on the inner aspect of it and disconnect the vein, put a small clip, and it's done. For us to do endovascularly, it's a little bit tricky. So we have to get right into the blood supply to the dura, and we inject with glue or with squid or onyx. The main point is to have the penetration across the dura, and glue sometimes doesn't do that. So it is very difficult for sometimes the glue to traverse across the dura, and you end up having a lot of arterial embolization, but nothing penetrates into the dura. And then you have contralateral supply coming across the midline from the opposite dural artery or the dural artery above or below the level. So that's what happens, and there is recurrence of symptoms. Also, when we inject, because the flow is quite rapid into the dural avium, you may not see the small spinal artery. And if you try to use embolic material like squid, and you would like to form a big plug, sometimes the squid can straight away go into the spinal artery, which you could not have identified because of the shunt being so large. It has happened before. So for the spinal dural avium, the clinical story is important, and you have to do the diagnostic angiogram to identify where it's coming from. You have to demonstrate the antispinal artery axis is separate level compared to the dural venous fistula. So that's what you have to do. And you have to take extra precaution to make sure you inject hard and long to see that there is no spinal radicular branch arising from the same division. And if there is ASA supply, I would advise that send patient for surgery. So here we are. So we are looking at spinal dural avium. So that's the branch coming up. So that's a horizontal branch, and this is the site of the fistula here. And then this is all the veins which are coming up all there. So that's the venous system here. And then that's T12 level, and the right L1 level, you have got the anterospinal axis. And then you can see the congestion in the cord at that point. Sometimes the spinal dural avium is better appreciated when you inject on the opposite side. So this is a site of fistula. So we have injected onto the right side, but the fistula is on the left side, and you can see the dural branch coming across the midline. Sorry, I should show the red. The dural branch coming across the midline, and that's the vein starting up from here, going up. So it's very easy sometimes. So you know that's the site of fistula is here, and that's where you need to disconnect. And this is the venous return of the dural avium. So if you inject long and hard, so you can see there is a spinal artery coming up there. So this is the veins which go up, and then you can see the whole cord is congested in that portion there. So because there was a spinal artery, so you can see that that's the spinal artery here, going up like that. So we couldn't inject glue here. I would not have got a selective position. So what we have done is we have put in coils in the intercostal artery. So that helps the surgeon to make a decision. So you can see the spinal artery is much better on the opposite side injection as well. And you can see that that's the dural avium. The venous starts from here. So this is the one which is straightforward for embolization. Here you have the artery going all the way, coming down and then coming up to here. And then the vein starts from here this way, going up. So that we can see this is the site of the fistula. So we can get with the magic catheter, we can go all the way there. So this is the tip of the magic catheter, and that's the site of the vein. And this is the glue cast. So you can see I got part of the artery, and then this is the penetration into the vein. So exactly the same vein as this one. So that is what we need to get. We need to get the glue going into the vein. Unless you demonstrate that the glue is in the vein, you have not cured the dural avium. So that's the post-embolization, and that's the pre-embolization. So this is another one with the spinal dural avium. So the dural avium site, the fistula site is here. So you got the magic catheter sitting right there. And this is the injection of the glue. You can see the glue cast going up all the way like that along the vein, exactly similar to that structure. And that's the follow-up where you can see that this was the congestion within the cord, and following the embolization, the congestion has disappeared. So this is how we demonstrate that. We move on to the spinal cord avium. So these are the second most common vascular malformation involving the cord. They present at much younger age when compared to the spinal dural avium fistula. So they are not congenital. So we have yet to find anybody who's been diagnosed to have spinal cord AVM intrauterine. So it's not. And usually they have a well-defined component. So what we see on angiogram is a lot of congestion, and that's the big portion of this. That's what we see is a nidus. But actually, there is just a single arterial shunt, and then lots of the veins. What you see like a nidus is predominantly most of the intrinsic cord veins which are congested. So when we have to treat this, we don't need to embolize the whole cluster. If we do that, what we end up doing is we cause venous ischemia. So we also end up causing obstruction to the venous outflow of the cord itself. So that's why patients don't improve. So we hardly have to inject much glue to treat a spinal cord AVM. It will be a drop or a half an ml or nothing at all. So spinal cord AVM has got male predominance, and the age of presentation is second to third decade. They usually have a very short duration of symptoms. Usual presentation is because of either bleed or a nerve root pain. So that's what happens. So, and common association is with this HHT and Klippel-Trenaunay. So the diagnosis is probably related to the subarachnoid hemorrhage because of the rupture of the AVM, or you could see cord signal changes, which is seen on MR, and the definitive investigation for planning further management is angiogram. So treatment, you could do endovascular treatment, which is a low risk compared to a surgical option. So I will explain what I mean by that. For embolization of the spinal cord AVM, it is important to get the guiding catheter in stable position. It would be 4F glide cat Terumo Cobra, which is my preferred one. And it needs to be negotiated into an artery over O3 to wire. So this is what I use usually to get it into stable position. And then selective angiograms, I do it with 1.2 magic FM. So it's got a different small green tip on it. And the main important part when I'm in the anterospinal axis is I have to get off the midline. So when I have to get off the midline, what it means is when the anterospinal artery comes up, sorry, let me do that in red. So when the anterospinal artery comes up like that, comes down, so you have to get off the midline like that. So when I'm in that bit here, so what it tells me is I'm in one branch. So if I embolize from here, so it's only putting half the cord at risk, and I cannot have any reflux. And I always use glue, so I don't use any other embolic material, because for other embolic material, you need to form a plug to push it forward. And as I said, the spinal cord AVM, the shunt is a very small shunt. Most of what you see is all the veins which are filling. We do not need to have significant venous penetration. So here, this is a young chap who presented with severe headaches and had a subarachnoid hemorrhage, and he had a spinal cord AVM. So you could see this was the aneurysm which had ruptured, and that's coming from the anterospinal artery, which is coming from the vertebral basilar junction. So that's the one anterospinal artery coming down there. So you can see that it gives off one branch which goes here, and another one here, and another one here. So I have to get in there. So the next picture tells you, so this is from the lower part of the vertebral. This is from the right vertebral artery. So you're seeing the lower portion of the anterospinal artery, and then you see the nidus, but no aneurysm here. So when you see, this is the lower portion, and also here, this is the aneurysm, but this is further injection. So you can see that this is the anterospinal artery, which forms the same connection from here. It continues down, and that's where the continuation is, exactly at the same level. So they form the whole length axis, and then on the side branch is the spinal cord AVM. So to treat this, I have to get into the branch. So what I've done is, this is the magic catheter, comes all the way up, down, up to here, and then comes out like that, and then into the AVM nidus. And here, if you see, this is the tip. So the artery is like that, and then I have come off and then come down like that. So this is what has happened. So I have gone off and turned all the curves, which is this curves, and all come down up like that. So that's where I've come, and then I've injected glue. So you can see here as well. So that's my microcatheter coming off midline here. And then after injection of glue, you can see I have preserved the whole of the anterospinal artery. And what I have got rid of is only this portion here. So that's where the aneurysm was. So that's the importance of coming off the midline. Okay. So this is a perimedullary AVM, which is the AVM on the surface of the cord. So this is the injection, which shows that the anterospinal artery comes here, that's the midline, but then it goes around the cord and the venous lesion starts from here, and then the slow veins come up from here like that. And then they go into the paravertebral veins out there. So this is a perimedullary, this is on the surface. So the difference between spinal cord AVM and spinal dural AVM is the age of presentation. Spinal cord AVM younger patients, while dural AVM is in the older patients. Spinal cord AVM has a shorter history, while the dural AVMs have a long progressive history. Now, from brain AV shunts and spinal AV shunts, what are the similarities and differences? So the brain AVM, you see large proportion of nodal component, which is predominantly arteries and arterioles, and veins, which are very small component, while in spinal cord AVM, you see one or two single arteries, but most of what you see is predominantly venous. So dural AVMs, it's almost the same pathology. So there's not much difference. Both of them are usually related to previous thrombosis and occlusion of the sinus or the vein, and then recanalization, which results in shunting. So we move on to the metameric AVM. So metameric AVM means the malformation extends to the entire element of the somite. So that includes the paravertebral portion. It includes the vertebral body. It includes, so the vertebral body is half of the lower vertebral body, half of the upper vertebral body, the disc in between. And it includes the dura as well as the cord. So here we have got the metameric AVM, where the shunt is on the radicular part of the nerve root. And then also you have a second shunt, which is here inside. That's where it is. That's a cord AVM. So that's what happens here. So that's how the metameric AVM looks. So this was a young lady who presented with AVM on the skin on the left leg, and had a rash patch on the buttock. And we could see vascularity on the left pelvis. So you can see that vascularity there. And then you had the shunt, that's the radicular portion. There is a shunt here. And then you have a spinal cord AVM at that. So that's the radicular portion. And then that's the artery goes up, and then that's where the cord portion is. So this angiogram we had performed in 2008. So this is later on, we had done this further investigations. We reassessed her, and we could see that there is still vascularity with the veins, paravertebral veins, and then they are draining into the spinal veins going up. And that's the anterior spinal artery. And if you can see, the AVM is predominantly only on the left of the cord. So the right of the cord is preserved. And then you have a large vein which goes down and makes a U-turn and comes up. And then it's only on the left side, you have the same artery which we saw previously. So you have the same portion which is forming part of the shunt is on the dura here. And then you have this artery which goes up and then has a shunt here as well. So that involves the dura as well as the nerve root. And then we are injecting the right side. So it shows the right posterior spinal artery goes up, then turns around and goes across the midline and has the shunt on the opposite side. When we inject on the higher level, so you see the posterior spinal artery again coming down towards the left only. So we can see that only the left half of the cord is involved. So we treat this by going across the midline, making sure we take the low risk procedures. So this was previously operated when the patient was young, and they operated, they opened up, and then they saw cluster of vessels and they closed, they didn't do anything. So you can see that's the laminectomy. And this is my microcatheter, which has come all the way here, taken the turn, come across, and then that's the tip of my microcatheter here, so which is here. So we embolize from there, and then this is the tip of the microcatheter. So we have gone down through this route, then come up all the way up to here. And that's where I have injected the glue. So following multiple sessions of injection, slowly the AVM starts disappearing, and this was the final anterior-spinal artery after it got treated. This was the immediate, the 2007 picture. This was the 2007 MR scan, and this is the current where the AVM has significantly gone down. It's not cure. We are not aiming for cure. The patient has got no neurology other than pain and slight weakness and spasticity. To cure this would be taking an extremely high risk. So we have always balanced it with, she also has got an AVM in her ankle. So we have always balanced the risk of treatment with a function as well, functional ability. So we didn't think that she had much of deficit for us to be aggressive in the treatment. So we kept over time doing small pedicles. So we used to come into the anterior-spinal artery and come off midline and then take this bit, then come off from here and take this bit. So that's how we managed to treat her. This is another patient who had a cervical metameric AVM. So he was treated in Oxford when he was quite young. And then we had our own service in 2007 in Preston. So this is the left-sided thoracocervical trunks, and it shows the anterior-spinal artery coming down towards this. And this is the vertebral injection, and that also shows the anterior-spinal artery. So you can see that this portion of the artery from here like that, and this part is nothing but from here, the same bit. So that's the junction where the anterior-spinal artery joins. So this is where it is. So these are the two. So this is vertebral injection, which is one level higher up, while this is the thoracocervical trunk. And then this is the previously embolized glue in the anterior-spinal artery. So previously they had injected glue. Luckily, he didn't have much deficit. So we can't access that bit. So that's what's happened. And this is a posterior spinal artery, which gives, which had an aneurysm on it. And then you had the AVM nidus, and then the draining vein with a stenosis at this point. So that was the kind of problem. And then we had from the lower portion, we could see that this is a posterior spinal axis, again giving rise to a big AVM supply. And that's the anterior spinal artery from the lower down. So you can see the anterior spinal artery going all the way. And this is fenestration because of the increased flow. And this is again the right-sided lower arteries giving rise to the posterior spinal axis. So when we embolize, we keep these points in, again, I'm reiterating that we use a 4 French glide catheter, and we navigate the glide catheter into stable position over O3 to wire, and then we use the super selective 1.2 magic FM. We get off the midline, always glue, and a very small drop of glue. So what we have done here is we have targeted only the aneurysm. That's the tip of the microcatheter, and we have disconnected that aneurysm in the shunt. So this is the post-embolization picture where the aneurysm from here was disconnected. This was done in December 2007. And that was the pre-embolization picture. And this is done later on. So this is the artery. So we navigated all the way through this tortuous artery, going all the way and reached up to here. So this is exactly the point where the microcatheter is, and this is all diseased vein. So we embolize from here with the glue, and this is post-embolization where we have disconnected at this point. So this is the point where disconnected the shunt. But immediately after, you can see that there is robust filling of all other arteries, and then they seem to be also connecting to the same vein distally. So then we go back into the same artery which was treated in 2007, which has another shunt developed. So we go there super selective with the magic, and then that's the glue cast. So we have disconnected this component of the abnormal venous shunt. So you don't need much actually. So that's just a little bit of glue just to take that. So that drops the shunt completely. And then we go through the thoracocervical anterior spinal artery, reach all the way. So here we can see that's the anterior spinal axis. So I have no access into these. So these are all, my catheter cannot go in there, and I'm not able to come off the midline. So I cannot embolize this. So we leave that alone. But lower down supraintercostal has got this appearance. So I can go here into these and go super selective here, and I can embolize this. So this is what I've taken off. So thus we have taken out these components of the AVM, that component of the AVM. So we've taken out most of it. But these are all normal veins. I don't need to get rid of these. I just take care of the shunt at this point, shunt at that point, and it starts making difference. This patient had come into the hospital and he was unable to move. So now he's stabilized. He's able to cycle to work. So he uses walker sometimes when he gets tired. And this is the follow-up angiogram. So all these arteries which we had embolized have now reduced in size and normalizing. And then you can see that there are still some shunts, but the access to this becomes very difficult because these arteries are too fine, and I have to get off the line to get into that. So that's for the next stage when if I have to do treatment, if he starts worsening, if there is increased venous congestion, I can target these lesions. The last bit of the talk would be the spinal terminale, phylum terminale AVM. So this patient had previous surgery at L45. Following this, there was fibrosis and she developed phylum terminale AVM. So that's the anterospinal axis, and the AVM is situated at this point, right at the site of surgery. So these are all the sepal veins. So that's the anterospinal artery injection. So this is again on the left side. So to put a magic catheter in will be very unstable. So I have to get it up to there, the Cobra catheter, and then able to get into that artery. And then we go all the way down into that up to the level of L5, just stopping short. And that's the vein coming up. So that's the vein coming up. And that's the glue injection. So the catheter is coming all the way like that up to here. And that's the glue injection. The glue injection is in the vein, and the vein goes up like that. So this is the post-embolization, and following embolization, patient has recovered. So, and this is our team. That's Dr. Sanwakar, Dr. Chatterjee, Dr. Rebecca Hyde. And we have support from Stephen Brown, Sam, and our neurovascular specialist nurse, Charlene and Ruth Pennington. We have had additional radiographers appointed in view of our expanding stroke service. So we got 3 more radiographers now. So that's our team. So that's the last slide of my presentation. Hope you are still okay with time. Yeah, perfect. Any questions?
Yeah, that's brilliant. So does anybody have any questions at all? Stunned side. Sid, I'm always in awe whenever I listen to one of your talks. You've got so much knowledge about this topic, and it's always fantastic. So thank you very much, Sid. I have a question for you, Sid. How do you when you're doing how do you pick your concentration of glue?
So usually I stick in spinal with 40 and 50% because I don't need much penetration. The shunt is quite small, and you have to be very close to the shunt, so I don't need to inject too much. So I don't need to do much variation. So it is always 40 or 50%. While if I have to inject for another brain AVM or anything else, so then I start injecting selectively and see how the flow is, how much I can pacify in the first few seconds. And that varies regarding the concentration. Anything less than 33% tends to fragment. So what it means is when you're injecting the glue, you need to have a steady column of the glue progressing. If it is too dilute, what happens is the droplets form and the normal blood comes in between. So you will have a droplet of glue, the normal blood, and then another droplet. So what that does is that causes problems where there could be additional recruitment of blood supply, and then you will have incomplete embolization. So you have to be very careful that if when you start diluting is less than 33%, you have to make sure that you inject a lot more glue and penetrate much more and get a good cast. Otherwise, it's a problem. We will have recurrence, and then it becomes challenging. About 33%, you will have a steady column of injection. All you have to do is go slow with the pace. For tumors, we use 16% glue. because for tumors, it's a tumor bed. There is no sump effect or anything which will suck into the glue, just like an AVM. So you have to actually literally push it in. So for that, 16% is good. And because we are doing tumors, most of them are meningiomas and they are external carotid supply. So we don't bother. So if we have a long reflux, we are fine. The only difference is when we deal with hemangioblastomas. Hemangioblastomas are very friable. So if you try to inject particles, you tend to rupture the hemangioblastomas and then they bleed and it is catastrophic. So I always use liquid embolic. Either it has to be something like a squid or glue. My preferred option is a glue. And I use anything above 25% glue for that.
Fantastic. Well, I think that's a great insight for everybody, knowing all that about the concentrations of glue, because I think it is pretty much the dark art of neurointervention. So thank you very much for all that, Sid, and all your knowledge. And yeah, look forward to our next session next month. So thank you very much, everybody, and thank you very much, Sid, for everything. And have a good evening, everybody.
Thank you. Thank you all.
Thank you. Therefore, I'll close the session. Thanks. Thank you. Bye.
Thank you. Bye.